All right. Well, good morning, everyone, and thank you for joining us today as we discuss our integrated psychology and pharmacy injection teaches in IBD patients with a presentation that we have titled Making Pokes Less Painful. So my name is Megan McNichol, and I am a clinical pharmacist on the IBD team here at Nationwide Children's Hospital in Columbus, Ohio. And I am joined by two of our wonderful psychologists, Dr. Jenny David and Dr. Hannah McKillop. And one of our patients, Victoria McDowell, has also graciously agreed to provide some content for this presentation, although she will not be here live with us today, but you will see her in a video later on. Next slide, Jenny. So here is our data confidentiality statement. Next slide. And none of us participating in this presentation have any conflicts of interest to disclose. So our objectives for today are to discuss the unique roles of both pharmacy and psychology within an IBD center, to evaluate efforts for pharmacy and psychology integration for medication injection teaches, and then to describe patient and provider experiences surrounding this integrated approach to injection trainings. And then lastly, we hope to give you some generalizable takeaways that can be applied to any IBD center, regardless of what resources you may have available. So I joined our IBD center as a clinical pharmacist back in 2018 and quickly was integrated into many aspects of patient care. Now, obviously, this is a psychology breakout session and I am not a psychologist, so I thought I would give a brief overview of kind of what my role looks like as an IBD pharmacist. So I'm involved in a broad range of activities across our center, such as providing vaccine recommendations for our immunocompromised patients, or adherence counseling for patients who may be struggling to take their medications as prescribed. I also work on several quality improvement projects within our center and assist with therapeutic drug monitoring for many of our biologic agents. And then I'm heavily involved in the medication access medication access for many of our patients and the prior authorization process for a lot of our specialty medications. Now, once those medications have been approved through a patient's insurance, then I bring them into clinic for a pharmacist-only injection training. So this is particularly for our subcutaneous medications, such as Humira or Stelara or methotrexate. And the patients and their parents come into clinic and I discuss the medication in more detail with them. And then I do some injection training and then we give the first dose together in clinic that day. So this particular visit and this role of what I do in clinic is going to be the primary topic for our conversation today. But before we dive into that any further, I'm going to hand it over to Dr. McKillop to discuss how her role, as well as Dr. David's, differ slightly from mine as the pharmacist.
Thanks, Megan. So today we'll be focusing on kind of the psychologist role specifically with the visits that Dr. McNichol was just describing. There's lots of other things that we do as part of the IBD team or as part of that. So today this slide is just to give you some ideas of possible ways in which psychology might be involved in these injection teaching visits. Especially for a patient getting an injection for the first time. But we also may participate if, for example, a parent has been giving the injection, but then at some point a patient has decided they would like to learn how to do it themselves. We are also part of that visit too, if they would like to have one. In summary, we're really there to assess any needs and any potential for procedural anxiety or distress when they're going to be getting their injection. And that information would tell us ways that we can be helpful in the moment when they're receiving the injection, also providing some anticipatory guidance for anyone, whether we expect or anticipate any procedural distress or not, because everybody can benefit from learning coping strategies and relaxation techniques. So really that's kind of our role, and then also to help them translate the skills that they learn in this particular visit to when they get the injection at home.
So as I mentioned earlier, the content of this presentation is going to be surrounding how we as an IBD center have created an integrated visit where both the pharmacist and the psychologist are present for the patient starting an injectable medication for their treatment. And we're going to talk about that shortly, but first I thought it might be helpful to take a step back and kind of hear how this process even came to be. So this is kind of the origin story of how we even came up with this idea. So as I mentioned earlier, historically, I, as the pharmacist, was performing these injection trainings independently. And one day I was in clinic and one of our IBD providers asked me if I could go into a room with a patient and do an injection training for a new sub-Q medication. And so I agreed to do that. I went into the room and one of our psychologists, actually Dr. David, who's here with us today, was already in the room reviewing some things with that particular family. And so when I think her curiosity got the best of her and she asked if she could just stay for the injection training portion of the visit and join me. And so she did. And I think what we realized very, very quickly was that there was quite an opportunity for psychology involvement in this appointment. You know, I did my regular spiel that I always do with the patients, but Dr. David had a ton of helpful tips and tricks that she could insert into the conversation as well to help this patient with their procedural anxiety. And so from there, we really worked to brainstorm what opportunities there may be in the future for future pharmacy and psychology involvement together for these injection trainings. And so that's really kind of where this all came to be. Next slide, Jenny. So after that, in June of 2021 is when we had this observation and came up with this idea. So then shortly thereafter in July, we brainstormed how we could make these integrated sessions a reality. And how would we identify the patients that might benefit from these sessions the most? And so we came up with some enrollment questions that we're going to discuss here together in just a moment to try to help identify which patients may benefit from these joint injection trainings the most. Then about a month later, we established a template for these injection trainings. So there were some barriers just in finding times when psychology and pharmacy were both available to do these. And so we came up with 2 dedicated time slots every week where we knew that both a psychologist and a pharmacist could be present to do these injection trainings and reserve those time slots on each of our calendars. And then in September of that year, we went live with these integrated visits. And it's been a great path since then. So after working through the logistics of these integrated visits, we established a quality improvement project to track the progress of this approach. So now, having done it this way for almost 2 years, we're excited to share some of the data with you all and talk through things that we have learned along the way. So for this project, our inclusion criteria were any outpatient injection trainings scheduled in our GI clinic on our main campus or via telehealth that were on the pharmacist on my schedule with an IBD patient. So really what was excluded were any injection trainings that were taking place in a location other than our outpatient clinic. So for example, we did not include any patients who received injection training while they were admitted as an inpatient, or if I performed injection training in the infusion clinic. So that is most commonly our patients on Stelara, where they get an IV infusion first and then transition to sub-Q injections. They were not included for the purposes of the study. We also did not include any injection trainings completed outside of pharmacist-only visits. So if a patient was also being seen by their primary IBD provider that day, they were not included in this data set. And any teachings for medications used for a non-IBD diagnosis were also not included. And with that, I'm going to hand it over to Dr. McKillop.
So the screening measures that we talked about, or the enrollment screening questions, this is just to give you a look at what kinds of questions we developed that we thought would help identify patients who may benefit from having us there if there's any anticipated needs beforehand. So Megan asks these questions, I believe, when scheduling these patients to get a sense of whether it would make sense for us to be part of that visit. So if we can try to schedule them at the times we had identified together, or if there's a time, if those don't work for patients and families, trying to find a time that works for everybody. Although we did try to have for each week, a morning appointment available and an afternoon appointment available to try to help with any scheduling preferences or needs. The questions really get at, as you're seeing here, specifically for visits for patients under 18, where they would need to have a caregiver present. if they've had any past experiences with needle procedures where they had a lot of distress, discomfort, pain. And this could be anything that they've had experiences with. Blood work. Most patients, by the time they would be scheduled for this visit, will have had an MRI where they needed to have an IV placed. Anything where, even vaccinations with their pediatrician, anything where they may have had an uncomfortable or negative experience in the past that might inform how they cope with or anticipate this injection going. Any pre-existing worries or stress about this particular injection experience, and any patients who have sort of baseline or pre-existing anxiety just in general, unrelated to needle procedures. And then kind of lastly, how they anticipate or expect it to go. And so this would help us identify anybody who we really wanted to make sure we could be present for if possible. Next slide is pretty much exactly the same questions, but just for our young adults who may not have a parent or caregiver present for that, and just kind of them being able to identify their own history and expectations. And so this kind of goes over in a little bit more detail about our roles. We had the other color box slide earlier. So this one, I just wanted to dive into a little bit more detail. So for the pharmacist piece, and Megan, at any point, feel free to jump in, but wanted to cover that there's a lot of anticipatory guidance that comes through this. And both Dr. Dave and myself have learned a lot from observing this piece. And so it's been great to sort of learn the pharmacist perspective and teaching and education that's provided with these visits. So there's like a review of the medication list and vaccine status, anything that might be important ahead of time, making sure that no medicines are going to interact with each other negatively. Some financial sort of feasibility and barriers with the medication, and just a lot of information about the medication itself, how it should work to treat someone's IBD, since we're suppressing the immune system to a degree. Some warnings about some potential risk for certain infections. And Megan is awesome in specifically talking about regional pieces. So this makes me think of histoplasmosis, which here in the Ohio River Valley, somebody might be at greater risk for. Really going over the specifics of the injection technique. And I ran down to clinic and borrowed her piece of fake skin here that she provides or brings to the clinic appointment. And then there's also a practice pen or syringe. So really kind of shows how this works to patients and families, and then gives them the opportunity to practice as many times as they would like before giving the actual injection. And then any side effects that might be part of the, there's usually those big commercials with lots of warnings that they read really fast, and those can sound scary to patients and families. So really covering the ones that might be of biggest concern to patients and families, and what to do about them if they do happen. And then the storage and stability piece, I always think about too, like our patients who are wanting to travel, and this is a medication that needs to be refrigerated, or if it's a college student living in a dorm where they're not allowed to have a refrigerator in their room, different options for that we can problem solve in the visit. And then the psychologist role is really kind of to intermingle our thoughts and our advice along with what Megan is doing in these visits. So I think, for example, the histoplasmosis piece that I mentioned earlier, some of our patients are excitingly involved in things like 4-H and showing their prize chickens, but we know that unfortunately histoplasmosis may be in their poop or in the soil that they're interacting with. So trying to help problem solve if this is an important thing for a patient. How do we help them do the things that are important to them? Like I mentioned, we talk about any past experiences, and then how we really help them cope with any possible distress or discomfort that happens when they're getting the injection, teach in the visit with us, and then how we carry over those skills and continue to practice them what to do when they're at home and doing this on their own. We found it really may differ based on age or developmental stage for these patients, in addition to whether there's any pre-existing or current anxiety and distress about the injection. And so we'll talk a little bit about our lessons learned and things, but really kind of targeting or triaging needs as they come up, and really individualizing it to the patient and family. We don't really have this quite on here, but observing family members too, and trying to model and help provide support if they're nervous or anxious about the process, especially if they're the ones giving the injection as well. And then some strategies to help make sure we continue to be successful with getting the medication over time. This is a copy of the handout that we developed to share with patients and families, especially if we weren't able to be present in these visits, but just want everybody to be able to have something to take home with them also to remember the strategies that we might have discussed if we were able to be present. And so we'll talk a little bit more about how to help patients and families, and then centers, if you don't have a psychologist that can be present on these types of visits, sort of how we may carry over this to your center. So the next slide goes into these examples a little bit easier to see here. So we might talk about things like distraction, and this may be different for each patient. One of the things that I might use sometimes, especially for younger patients, is something called the alphabet game, where we go back and forth between patient, family member, and ourselves to name different animals that start with different letters of the alphabet to kind of keep their attention on something else. If half of their attention is on the game that we're playing, that means half is not on the needle going into their skin, and so it may help them feel more comfortable as that process is happening. Relaxation techniques that are evidence-based, like diaphragmatic breathing, muscle relaxation. We know when we're anticipating something to be painful, we're likely to tense our muscles up and guard against it, which unfortunately may make the injection more painful. So really trying to consciously train the muscles to purposefully tighten and then purposely relax so we can release some of that muscle tension that might be there. I also brought to show our little Buzzy Bee device. Let me see if I can get this to work with my blur here. So sorry about that. There we go. So this is a little handheld device that vibrates. And the idea being that if we put this somewhere on the skin, away from where the injection is being given, the brain is paying attention to the vibration and not so much to the needle going in. So same kind of concept, but really specifically looking at how the brain processes pain and stimulation. Also comes with some cute little wings that are like a cold pack that may help with that sensory sort of distraction as well. And a couple other tricks that we talk about too. And we really like to share as many possible tools as we can for somebody's toolkit. What they may use one day may not work and they want to try a different one, and that may be what they like to use moving forward, or it may depend on the day or how they're feeling. So we like everybody to have a vast toolkit at their disposal.
All right. So we've already learned a lot about what we've been doing so far, and I want to really dig into a lot of the QA processes that my colleagues were talking about. And then we'll also have a chance to look at the data and our run chart to also understand more about what we've been doing over the past near 2 years. So this is our key driver diagram, and we're not going to read you every single text box because that might take some time. But our global aim is really to increase access to psychosocial care for IBD patients, particularly during injection teaches, for kids where we know that have historical, so past or current and the present procedural anxiety programs. Our specific aim, since this was a brand new bill for programs, was to increase integrated pharmacy and IBD psychology injection teach visits for IBD patients at the outpatient GI clinic here at the campus from 0% to greater than equal to 30% by the end of February 2023. You can see here that there's a variety of drivers and interventions. Some of the drivers include IBD psychology being aware of the experiences that patients have had, and if there are known challenges, both either in the past or kind of right now challenges for procedural anxiety, or psychologists being aware and willing to have us there, families being aware of what IBD psychology can do, and then having all of the appropriate resources and tools that Dr. McKillop was just showing us, including that handout. And then, of course, a variety of interventions too. Appreciate the feedback. We'll come a little bit closer to make sure that the sound is a bit better, but please feel free to let me know. Awesome, thank you. Okay, a variety of different interventions that my colleagues have already talked about as well, like the different screening tools, purchasing Buzzy Bee, making sure we had time on our templates, and having those designated times to schedule families into. So this is our run chart, and you can see there's a lot of things happening. So we're going to talk through things slowly. You can see on the horizontal axis here, this are the different months. So we start from June 2021 to February 2023, which was the end of our SMART aim, as you'll remember. And then on the on the vertical axis, you can see is the percentage of integrated injection teach visits for the IBD patients in the outpatient GI clinic. we can see that a desired direction is to go up, since our smart aim is to go from 0% to greater than or equal to 30%. And that 30% we can see marked here in a green horizontal dashed line. The red line here is the median, so we can see that's a little bit higher than our goal line here. And a lot of different things are happening. We see the different trends here with the kind of pinkish red background, and those are the different interventions and things that we were doing during the time that we wanted to mark. One thing that I'd love to draw people's attention to, if we look at this box down here, where we see all the different months and then the total teachers as the denominator and the psychology involved integrated teachers as the numerator, we can see that there were some months like July of 2021 where we only had one instruction teach that month. And then other months like February 2022 where there were 12. And so this really varied a lot, as well as the psychology integration. There are a lot of different things that we did at different, as you can see here. So we probably did the screening questions, self-identifying. Wonderful pharmacists will reach out to us and when patients are being scheduled. But then you can also see, closer to November of 2022, we were also beginning to staff the pharmacist's schedule to make sure that we were taking some burden off of her plate too, since she is incredibly busy here at Nationwide. We also began to offer some psychoeducation and anticipatory guidance to families that these types of visits were possible. So Dr. McKelvey met someone during their integrated IBD teach, so not the injection teach, but a new diagnosis teach. And they were going to be starting on Humira. Then we would let them know, like, hey, we have this cool resource. And then giving handoff to Megan of like, hey, Buddy's going to be having an injection teach, they'd really benefit from an integrated teach. Or if there were patients that Hannah saw in clinic or inpatient care, where, like Hannah was pointing out before, the developmental needs might have changed, that maybe they began on Humira when they were 8 and now they're 17 and really needed to give it themselves, but having a challenging time, then we could also offer a reteach and then coordinate with Megan to make that happen. And then most recently, having that handout provided and like Hannah was to being able to provide that to all patients, even when the injection teachers weren't supposed to happen with IBD psychology. And so we overall did surpass our goals, but we can see a lot of different things were happening. Some of what was happening when we were looking at the data as a team, that many of these patients keep coming closer. I appreciate everyone's feedback and patience with the audio here. That many of these patients were seen for IBD teaches or other types of touch points with IBD psychology in the standard of care here at Nationwide. And so we'll present more of that data in just a moment here. Okay, so we wanted to present really a summary of the data, and we'll look at, was it a first injection teach or reteach, the subtype, the gender identity of these patients, the age range of these patients, and then what medications that they were receiving. And for all of these different tables here, the integrated teaches are highlighted in this purple shade. So we can see in this first table here that we had 113 teachers all together. We had 40 teachers that were integrated with IBD psychology and pharmacy, and 73 that were not integrated, that were pharmacy only visits. We can see that the vast majority across those two cohorts of integrated and non-integrated teachers were first injection teaches, and then a very small number were reteaches for our patients. Let me look at the subtype of IBD that our patients had. The overwhelming majority across those two groups of integrated and non-integrated Crohn's disease, about 20% in both groups, colitis, and then a pretty small percentage had indeterminate colitis between those two groups. When we look at gender identity amongst the patients that we saw during this time, it was about evenly split between female and male. And then we, interestingly, had more people who identified as gender diverse in the integrated teaches than the non-integrated teaches that were able to capture a variety of genders across the different visits. And then we looked at age. The total age range of this 113 cohort was from 6 years of age to 27 years of age. The young person who was 27 years old has a medically and developmentally complex picture, and so is still receiving care here at Nationwide. And we can see, which is interesting, the average age, when we look at the mean for the integrated teachers, was over a year younger than for the non-integrated teachers. And this may give us some insights that our younger folks may need additional support or may be more likely in a very developmentally appropriate way to have more thoughts and feelings about having an injection. When we look at what types of medicines that folks were receiving, and my colleagues have already talked about the different medicines so far, between the two groups, most kids were receiving Humira, then the second most common was Stelara. What's interesting that I'll draw people's attention to, like Megan was already hinting at before, since Stelara's first dose is in the infusion clinic, it's perhaps not surprising that there's a higher rate of young people who didn't have an integrated teach on Stelara, who perhaps had pharmacy teach in the infusion clinic or in another setting. We had a small subset who were on methotrexate subcutaneous injections, and only one young person who was on Skyrizi, who was someone that was a patient of mine. So I was seeing her in other types of care and didn't have an integrated teach because family had politely declined that. What's interesting when we look at just the 73 young folks who did not have an integrated teach, almost 70% of those young people are followed by one of our IBD physicians versus the 30-ish% that were followed and are followed by a GI provider, but not an IBD subspecialist. The reason that this is important that we wanted to highlight here in this presentation is that here at Nationwide Children's, for the folks who are followed by an IBD subspecialist, there are additional opportunities for Dr. McKillop and I to see them during a clinic visit and other times of care. And so those are young people that are also going to have an increased access to IBD psychology, just in standard of care here at Nationwide. Like my colleagues have been talking about, patient experiences can really vary, and we need to be really thoughtful about what is going to be most personalized to that person's experiences. It's really helpful for us to understand how have you coped with these things in the past? What is helpful when you get your annual flu shot? What has been helpful when you had your IV for your MRE? To have a sense of what has helped in the past, what hasn't helped, what challenges have been. If there's been a lot of anticipatory anxiety the day before or the morning of, how might we address and provide evidence-based interventions that are still targeted and individualized. It can also be helpful to understand that what is stressful might change with the patient. So we've had many patients who really benefit from having a countdown to the poke, and that can help us time and exhale, like a long breath out as the poke is happening, 4 times in deep breathing or a distraction. And then other young folks who tell us, no way, that is super stressful and that makes me have more anxiety, knowing that the shot is coming. And so helpful for us to be thoughtful that, again, these things can be very different and that coping for all of our young patients can change over time. So someone who starts on Stelara when they're 12 may need different coping skills when they're 16 or 18 or 20. And it's important to remember that coping is a dynamic process and is not a static thing. And that we always need to be providing support and psychoeducation and different recommendations to make sure that we are seeing someone as a whole person and recognize that even resilient folks need ongoing support because they are still humans. But we have someone who could do a much better job of talking about the patient experience. So we're going to show you a video of Tori. She is fabulous, and I'm sure everybody's going to fall in love with her. Her mom did a great job of reading off the different questions that our team had asked Tori to talk about. So Tori had an integrated IBD injection teach with myself and Megan back in December 2022. And she's also a really cool young person that's been followed by both Dr. McKillop and I in regular IBD clinical care. So you'll hear Tori talk firsthand about what her experiences were and things that she thinks went well, things that she thinks should change in the future. Also helpful to note that when Megan and I walked in the room and we had Buzzy Bee in the box, Tori, in a very animated fashion, was like, no, thank you. I do not like Buzzy Bee. And so we mirrored her interpersonal style, and we kind of emphatically put Buzzy Bee in a place that was not visible. And then you'll hear her talk about, as we talk more about like, what is Buzzy Bee, how it can be helpful, and give her the opportunity to try it out and just see it, touch it, feel it. Then she became a big Buzzy fan. But I will leave that up to Tori to tell us. I turn up the volume so everyone can hear. It's about 3 minutes long, and she does a great job as she's squeezing her squishmallow here.
Okay, Tori, so what was your experience like starting the injection medication?
So I was really scared at first because I used to not like shots at all. But after they showed me how to do it, I felt a little bit better. And then I realized how small the needle was, and it was pretty easy after that.
Okay. Did the pharmacy and psychology team, the injection lesson, better prepare you to receive the medication when your mom and dad does it for you?
Yes.
Yeah.
Because it makes you be prepared if they need a little bit of help or if they want me to do it on my own. So.
Did the psychologists being involved help you be brave with the injection medication?
Yes, because I know they wouldn't let me freak out.
Did
or
they
get
teach
too
you
scared.
techniques to like deal with it a little bit better?
Mhm.
Awesome.
Yeah, they did.
What tips that they taught you have you used at home to help you with having mom and dad give you the medication?
I learned that you had to relax because then your fat's gonna get like sucked in if you have any, or if it's just skin. Because
You don't have much
anything on me.
fat.
I don't have a lot, so I had to like stick out my stomach, which helps my mom. So yeah.
What tips that you learned at the injection class do you think would be helpful for other kids that have IBD and their parents that have to do it at home or?
So for parents, I think you should like let your child know when you're gonna press the button, because my mom does that, and it's like, oh, okay, the injection's going in. And for another thing is you might want to buy them a stress ball, so that they can like squeeze it if they're a little bit nervous.
Okay.
But just don't tell them to squeeze too hard, because then it's gonna like explode and pop everywhere.
So is that the tip you would give to kids?
Just be brave, because for those who are afraid of needles, I was like you, and it's just like, oh, injections, meh. you learn from it, basically.
Is there anything that you would change about the experience with the pharmacist and the psychologist at the teaching visit? Would you change anything?
Yes, I changed when I didn't have a panic attack in the bathroom, basically.
No, I mean, what would you change about them teaching you? Is there anything?
No, nothing.
You think they did
Nothing
a
at
good job?
all.
Okay.
They're really nice.
Okay.
The only thing I would wish is that I wasn't so freaked out about Lizzie.
Is there anything else that you think that that you can tell them that would help them teach other kids or help parents deal with children?
Just say you have to be brave, because I know it can be a little bit scary or just annoying when you have to switch medications so much. It's just you're hopping around from one thing to the other, but once you find your thing, you just gotta stick with it.
Yeah. What about the injection? Would you say that what do you think is the hardest part for you for the injections?
Probably waiting it for to go in, because I'm like, is it gonna go in? Is it gonna go in?
Does it feel like it takes a long time and then?
A little bit, yeah. It feels like a minute or so or two, but it's only like a few seconds.
Okay. All right. Thank you, Tori.
We want to thank Tori and Mom. That was incredible, and she talked about a lot of really important things. We, like many ICN providers, take a real strength-based approach. You hear her talking about being brave a lot and about how she had some more procedure anxiety in the past, and that through talking it out and having different tips and tricks, she feels really differently about it now, and has also done a nice job of talking about what works for her, offering different ideas. We're really proud of Tori. I want to thank Tori and Mom for contributing. Oh,
okay.
As much
Tori,
as we love to watch it again, there's more content. Sorry, friends.
Thanks, Jenny. So one of my favorite parts about the ICN conference always is the patient and family shared experience. So I'm so glad we were able to get Tori and her mom's experience with that. So we wanted to share some wins and lessons learned from this process. When Megan said almost 2 years now, I can't believe that it's actually been that long. So we've had a lot of time to reflect, though, which has been great. So certainly some wins is that we really are trying to increase the equity of the psychosocial care provided to our patients and families. I know Jenny and I just try to be available in as many spaces as possible, because we know that there's lots of different ways that our patients and families interact with the hospital system. And if we can help people feel better or cope with different parts of that, we try our best to do that. And this was an area that we found could be helpful. We really want to promote positive coping for all patients, even ones who don't have identified needs as far as procedural anxiety or distress. Like I mentioned, we know that everybody can benefit from relaxation techniques, not just for needle procedures, but for other aspects of life in general and or medical care. This provided each of us some interprofessional education, certainly too. So I know that I've been able to share some anticipatory guidance if I'm not able to be in some of those sessions, and sort of this is what it looks like, and here's like an idea of some of the wonderful things you're going to learn from Megan when you're going to be part of learning these injections. But then it's been great for us to learn from each other, and then really just kind of demonstrating the value of the integrated multidisciplinary care to patients and families that we value so much as an IBD team here. Some lessons learned, certainly not all patients need that integrated visit. And so we want to optimize existing resources like that handout. Again, everyone can benefit from learning those tools, but don't necessarily need us there coaching in the moment when somebody's receiving their injection. And really, we want to provide that individualized treatment tailored to each patient and family. And so those coping plans may look different. Tori did a beautiful job sharing the things that worked really well for her. But we know for some patients, they absolutely do not want to know when that shot is going to go in. And some patients really want to look. Some people don't want to look at all. Some people feel like they want to look, but then it actually makes them feel more anxious when they do. So we really try to tailor each situation to each patient, what types of relaxation strategies they need, what the setup looks like when they're going to be getting their shot at home. How do we do all of these things when we get home as well? And next slide. So really kind of just wanted to share some final lessons and learned as far as how we can maybe potentially use these things in other centers as well, using the lessons and wins that we've had. We recognize that not every center has a pharmacist that can do these types of visits potentially, or psychosocial providers that can be present in an integrated visit. And so we wanted to provide some recommendations to different centers. So what tips and tricks could be useful? We hope we provided a good overview of those things today, and trying to help support patients' psychosocial needs, patients and families' psychosocial needs during injections, and sort of learning how to do this and integrate this into their life every week or every other week, or more with Stelara. What resources do you have at your center? Do you have a pharmacist or a psychologist or a social worker who provides therapy and support in those ways? Or are there others who could potentially implement similar concepts in the setup that you have in your clinic and setting? If psychologists are able to see patients in clinic but have limited time for these integrated visits, are there things that can be done in advance, providing anticipatory guidance, recommendations, handouts like the one that we showed you? We actually have BuzzEB sitting in a drawer in clinic so that anybody can grab it if they would like, including our nurses or providers. I think Megan brings that to the appointments when we're not able to be present too. So having different things available. We know that BuzzEB is not also financially feasible for every patient and family or center, and we've heard some really creative ideas about how to use the concept. Tori mentioned a stress ball for herself that was helpful, but I've also heard families who have gotten like a little handheld massager that you can get at like Bath and Body Works or Bed Bath & Beyond, or those kinds of things that kind of serve the same purpose. And learning a lot of the free coping and relaxation strategies that we talk a lot about as psychologists. So we wanted to provide some ideas for your team today and how to collect those resources to support those trainings and then implementing them at each center.
Great. So overall, we're really excited about the strides that we have been able to make thus far in this project, but certainly have identified other areas for improvement and expansion. So wanted to briefly touch on some of those. So I think for us, our future direction with this is to expand our data collection to collect all types of visits. So those that are happening in the infusion clinic or inpatient and things like that. We hope to expand this project to collect that as well. We also want to analyze the impact of that screening tool that we mentioned previously. So that is something that I'm using when I'm scheduling these appointments to try to better identify who might really benefit from this integrated visit type, but we haven't actually try to draw any conclusions about if that screening tool is effective and if we're capturing the right patients as a result of that. So we're hoping to do a deeper dive into some analyzing of that particular tool. We also hope to automate a psychology referral when these pharmacist-only appointments are scheduled. I will be the first to admit that oftentimes these injection trainings get added to my calendar and I fail to reach out and notify my wonderful psychology colleagues that a patient has been scheduled. And so I think that would just be one more way to make sure that we're capturing as many patients as possible when they're scheduled. We also want to continue to collect patient feedback and suggestions. We know that at the end of the day, they're the ones that have to go through this experience. And so we certainly want to know how we can better support them and make them feel empowered to do this on their own at home. And then continue to expand the resources that we have for our patients. We have that one handout that we showed you and that we're hoping to provide to you all today as well. So you can certainly use that at your center if you would like. But we want to continue to expand the resources that we have available for our patients. And then also to provide ongoing interprofessional training opportunities. Like Hannah alluded to, I have learned so much from just listening to the psychologists, and if they're not present for a visit, there are so many tips and tricks that they have that I'm now able to use even if they're not present. And I think they would say the same is true for them as well. So I think there's a lot of benefit of this interprofessional work and things that we can be doing even behind the scenes as an IBD team to better educate one another on some of our areas of expertise so that if the other, interprofessional person is not there, we still have the opportunities to share some of that valuable information with them. So in conclusion, the integration of pharmacy and psychology, we feel can really lead to improved injection initiation in the outpatient setting for a lot of our patients. We believe that the interdisciplinary approach allows each provider to focus on their area of expertise. But we also feel that the techniques used that we're using in our center are certainly generalizable to any IBD center, even if you have variable staff resources. So if you have nurses that are doing these teachings, how can a psychologist integrate with them? Or if you don't even have a psychologist, what tips or tricks can you take from maybe the resource sheet that we have to implement into your center and into your teaches? So we hope that this was helpful for you all, and we are more than happy to take any questions that you might have.